Good morning, everyone. It's really good to see you this morning. Glad that we can be together, even in this remote way. It's a fascinating thing to be the host of a Zoom meeting and see folks come on and see the expressions on your faces as you're intent on whatever it is you're doing or just waiting for something to start. It's really always a delight and a blessing to me to be able to see you and to gather together. I'm thankful for each one of you and for the work that you continue to do. I want to give a brief shout out to Pastor Marsh Dregge. Yesterday was the Right to Asylum virtual event online. Very well done, sir. Very well done, and a really good reminder of the work that the church is called to do. So thank you for that ministry and for lifting that up last night. Our own Christopher Vergara was one of the honorees at that, so it was a good event. So I'm glad that we could be together. This is a wonderful opportunity for us to learn some more about the times that we're in. You all play such an important role in bringing communities together and establishing trust and helping people to feel a sense of comfort and a way forward in very difficult times. That is in a way our calling, part of the essence of our calling. But what I'm really excited about today is that this gives us a chance to understand our role as faith leaders, also as resources in the area of public health, not just during a pandemic, but in general. And these times as well, as we move forward in addressing the COVID pandemic and continue to address systemic racism and its effect on people's health, which is one of the most dramatic things that I've learned in these past 7 months. We are very blessed and fortunate to have Dr. Susan Michaels-Strasser here to provide 2 webinars for us, one today and another one tomorrow evening, bringing us up to date on some information about COVID-19 and the impact that that has on our ministries. Today will be an overview of what is currently known. Dr. Michaels-Strasser will share some of her work in addressing COVID-19 and then target that information to how it affects our churches here in New York, in the US at large, and even globally. That's how far her reach extends in terms of her work in healthcare. We'll give you the best, well, Dr. Michaels-Strasser will give you the best up-to-date information about transmission, prevention, mitigation strategies, what's the latest about a vaccine. You probably heard some of that on the news today, and then discuss how this can affect you as you continue to plan your worship and plan ways to serve and strengthen your communities of faith. I'm going to ask Roberto to give a few brief instructions about how we're going to conduct the webinar, and then I'm going to pray for us, one of my privileges, and then I'll formally introduce Dr. Michaels-Strasser. Roberto?
Thank you, Bishop. And hello, pastors. Welcome again to this webinar. My name is Roberto Lara. Some of you already know me. I'm the assistant to the Bishop for Communications and Development. But before we begin today's presentation, I just want to give some information related to our time together in Zoom this morning. So some pastors were not available this morning. So we are recording this webinar. It will be available in our COVID-19 resources pages in our website, MNYS.org, by the end of the week, and also will be included in our email scheduled to be deployed this weekend. This is a very large Zoom meeting, so everyone will be muted to avoid background sounds and make the experience more pleasant for everyone. However, if you have a question for our presenter today, please add it to the chat feature. If time allows, questions related to today's topic will be answered during our Q&A period at the end of this webinar. Any information related to any unanswered questions will be published to our COVID-19 resources page. So that page gets updated constantly, so please keep visiting our COVID-19 resources page at MNYS.org. And finally, Pastor Arden Strasser will be helping us to moderate the Q&A session at the end of the webinar today. Thank you, Pastor Arden, for helping us with that this morning. And I think that's all I have from my end.
Okay.
So back to you, Bishop.
Thank you. Let us pray. Gracious God, we thank you for this opportunity to gather as your people, to gain wisdom and understanding for the work that you have called us to do. And in this wisdom and understanding, to find renewed confidence that you and we together are adequate to the tasks that face us in these days. That you and we together are more than adequate for these opportunities to be the church, to serve in new and creative ways, to serve in ways that continue to sustain your people, to serve in ways that stretch us and help us to grow. This morning we give you special thanks for Dr. Susan Michaels-Strasser, for her wisdom, for her knowledge, and for her willingness to share that with us. We give you thanks for all these faithful servants and so many others who continue to answer the call day by day. I would pray that you would keep them strong, keep them safe, keep them calm, and help all of us, Lord God, to remember to breathe, to take into ourselves your Spirit, and to be renewed. For we pray these things in Jesus' name. Amen. So, so delighted to have Dr. Susan Michaels-Strasser, PhD, and a number of other initials after her name with us today. She is the Senior Director for Human Resources for Health Development and an Assistant Professor of Public Health and the Division of Epidemiology at Columbia University. She's got over 25 years experience in nursing and public health and is the Principal Investigator for the CDC and HRSA-funded programs in the Democratic Republic of Congo, South Africa, South Sudan, Sierra Leone, and Zambia. Pastor Arden Strasser is very fortunate that Dr. Michaels-Strasser happens to be his wife. He serves at St. Luke in Manhattan. And we're very delighted, Dr. Michaels-Strasser, that you took the time to be with us, and we're anxious to hear what you have to share with us. So thank you.
Thank you, and thank you all for joining. Can you hear me okay? Maybe just give a wave. Okay, great, thank you. And it's really a privilege to be here. And this is, I feel, in some ways, a culmination of a lot of years of work and experience working with Arden, not necessarily formally within the church, but working together throughout our lives in public health and in faith. And we have been privileged to be able to walk a path where he could do his work first in engineering and then as a called pastor, while I worked in nursing and public health. And of course, we affect each other greatly. And my slides today are affected by some of his insight. And I've learned a lot over the years by walking with his journey in the church, but also reflecting on my role as a pastor's wife and my role as someone of faith in public health. And this became glaringly clear when I worked on Ebola in 2014 in Sierra Leone. And I've really had time to discern, especially when we were at home in quarantine or in lockdown, thinking about what is really going on here. And that's what I'd like to get us to at the end of the discussion today. Today, I'm going to focus on looking back at what we know, what we've learned over the last 6 to 9 months. And tomorrow's talk will go into the future, specifically with vaccines and looking forward. But it's important to look back at our history. How did we get here? We are the country with the largest number of COVID-19 cases in the world. And there are some fundamental societal value-driven questions we as leaders and you as faith leaders need to be asking of ourselves, our communities, our leaders in public health, in academia, in government, in leadership that drives public space, public discourse, and the way that we interact and work with each other. So my talk will focus on the science and on the public health, but it comes from a deeper lens of looking at what's really going on here beyond just a virus. Because we know, and all of you have seen, the profound importance of personal behavior and people's collective behavior on public health. And that's where I want us to go and be able to think about not only for now and getting out of this pandemic, but towards the future, because I think God always gives us moments in time where we are challenged, and those challenges are to think more deeply, think more critically, and to discern what does this mean to people of faith, and how do we build a more just and honest and loving society. And not often the words you hear from somebody as a scientist, but I firmly believe this. And the reason I believe this is I've seen it time and time again. I started my work in HIV and have worked more increasingly in areas of epidemics like Ebola. And I saw in the midst of the worst days of Ebola in October 2014, yes, we had an epidemic. Yes, we had death and destruction. But it was the way people interacted, the behaviors of people that drove a problem or drove a solution. And to me, that transcends all of the medicine and the science, and really gets to the power of communities and leaders in driving change. And I remember in my time in Sierra Leone, I was asked to look at what is called community care centers, because when I got there, it was bizarre. And I'm sure all of you have felt like the last 9 months are bizarre and you're living somewhat in a dream. And you see, oh yeah, we're all wearing masks, how strange. Or all the kids aren't going to school. These are affronts to what we know are normal. And when I was there, I had the contradiction of people, I don't want to be too grim, but people sick, really sick on the side of the road from Ebola. And down the road, people building with bricks and mortar an Ebola treatment unit. And it was like watching people building a bridge as the tsunami was coming. And I looked at that and saw how the tragic comedy of that, people trying to build a building to save people when people are on the streets, sick, deathly sick. And it made me think about, what are we missing here? And we missed a lot, and we've missed a lot in this epidemic. And that's what we want to really get into. That's the rich discussion of how do we capacitate communities? How do we use the strengths and resources we have within us, including community leaders, to respond now and to respond effectively with what we have? And this epidemic has taught us that what we have that is most powerful are the most simple things. Doing what we know needs to be done, wearing masks, hand washing, social distancing. These are the most powerful treatments, preventive strategies we have right now. And it's ironic that these are the cause of most controversy. So let me get started. I was afraid I wouldn't have enough to talk about, and unfortunately I always have too much. So let me get into the presentation. One moment. Okay, are you able to see the slides?
No, Pastor. Sorry, no, Doctor. Are you sharing your screen?
Yeah, I'm going to try to do it now. There we go. Okay, you should see it just now. Okay, great. Okay, so let's get started. I have many slides, and I will share the slides with you after the talk. But I won't belabor every one of them. I wanted to leave them in for information. So this is titled Reflection for Action, Faith Leadership Amidst COVID-19. So I wanted to start with a bit of a background so that you just have that general knowledge, which gives you some confidence as you are talking with people. So what do we mean by a novel virus? You heard this early in the epidemic, and novel is just stating that we have something new that has never been seen before. We have seen what are called coronaviruses before, but not one that looks exactly like this one structurally. So coronaviruses, we know, are large and enveloped positive strand RNA viruses. You don't really need to know that detail, but just to know that it's because of this shape on the virus that it looks like a crown. And it's named for that outer fringe or that corona. There are many known strains, and it's important to understand that it's mostly living, this virus, this coronavirus, is living in birds and mammals. It's been with us probably since time immemorial. But there are a number of strains that somehow adapt and change that can then infect humans. And 4 of these account for 10 to 30% of all mild upper respiratory tract infections in adults. So coronaviruses, respiratory viruses, are not new. It's this actual type and shape and behavior of the virus that is different. And 3 strains are known to cause epidemics. And the reservoir, we call it zoonotic. Just think of a zoo with animals, but usually wild animals that are likely to harbor or hold these naturally, like we naturally have strep and staph in our nasopharynx. And it's usually in bats. They have also seen it in pangolins, and in this case of the novel coronavirus. And somewhere along the way, there is what we call a spillover from viruses of the virus from the bats and a jump to human beings. And we call this a zoonotic disease. And one of the leading microbiologists made the quote, "It may be once in 100 years that the alchemy or the experimentation, the natural experimentation in society, in our environments, is right to infect humans. And when it does, it takes off like wildfire." And that is what we have seen. And you can see the bats coming up on the screen here. As we encroach on habitat that is natural to animals, and we interact with them more and more with wild animals, not domesticated and carefully controlled animals, but with wild animals. As we have more populations going into more rural and underdeveloped areas, this risk of jump is great. So it's not surprising that we saw a jump where, and the source most likely coming from an area where there are a lot of wild animals being sold. So what is the difference between SARS-CoV-2 and influenza? We heard a lot, especially earlier, well, it's the flu. And it's definitely not the seasonal flu. What is different is we have vaccines and treatment for influenza. And if you haven't gotten your flu shot for this year yet, I would encourage you to go. Many people have some immunity to seasonal influenza from earlier years of illness and exposure. And both viruses are similar in that they cause similar symptoms. But the incubation period for flu is quite short, and the incubation period for COVID is longer. So people are slowly developing the symptoms, and I'll talk a little bit more about the symptoms. So they have some similarities, but definitely are not the same. So let's look back quickly as we begin to unpack this. We know that the virus came from an origin somewhere around Wuhan, China, and there was lots of discussion of the open market and that being the source. I don't know if patient 0, as we call it, has been identified, but this is, in my opinion, something we can look at later and discuss later. Right now, we're in the midst of the epidemic, and we need to think about how to respond more effectively. But that is where it all began. And then in March of this year, WHO declared a global health crisis. And that was after the virus had been circulating in Asia, in China, since late December. And so when we think about the United States and where we've been with this virus, I was looking back at some of the older statistics, and this is from March 17th. So just around the time, a week after the WHO declared a global health crisis. And we had very few cases of COVID-19, but we knew it was very serious because people were becoming very ill and dying, especially the elderly. But you can see in March, when you think back to March, as we were beginning to start to consider a lockdown, we had less than 10,000 cases. And you can see here I'll use my cursor to show, this is mainland China cases coming from January. We could see the numbers went up quite quickly, but then they began to level off. And in other countries, and people slowly recovered. The numbers of people slowly increased. But what we can see from all other countries is there was what we would call really a ticking time bomb of this lag period where there weren't cases in other countries, but then suddenly we see a very dramatic jump. And this is what the professor was talking about when we have this alchemy, when there's a novel virus and things can take off like wildfire. And we saw this exponential increase in the number of infections, surpassing that which was seen by mid-March in Wuhan, China, in mainland China. And this is a picture from New York, from one of the hospitals downtown that I took. And this was in about July. And by that point, so going from that March number of less than 10,000 people to a situation in New York City where we needed to bring in refrigerated trucks. And it's difficult to see here, but this square white rectangle, truck is actually a refrigerated truck for the bodies, because there were so many people dying, and we knew, all of us have lived through that time when our hospital systems were really over capacity and we had to take extreme measures. So what are the challenges and opportunities that we are confronted with knowing that we have this novel virus? So challenges to epidemic control. First, we have a novel virus. We have no natural immunity, although some people who have been infected and recovered, many of them, we hope, have longstanding immunity, but even that is not certain. And I heard this morning of a case of a young man who has been infected again and is actually having a worse presentation this time. So had been infected, recovered, and is now gotten another infection, a separate infection, and is having a worse course of disease. So we don't have that natural immunity. It looks like some people develop immunity, but we do not know how long it lasts or how robust it is. And there is no vaccine, and we'll talk tomorrow about where we are in the progress of getting a vaccine. And there are no known therapeutics, although some are emerging. Asymptomatic infection is also a tricky component of this epidemic, in that we have this silent spread, people that are infected but feel fine. And this is a virus's way of surviving. It's doing what it needs to do to survive, to be able to replicate and continue to live. And so viruses are very tricky in that they learn how to trick our systems. Some people become very ill and die, but then many, are asymptomatic or have very mild symptoms. And this allows for the silent spread of disease. The third variable and challenge is we have what is called an R0, or a replication number that is greater than 1. So if I'm infected with COVID-19, I am likely to infect at least one person, but more likely more than one person. And so when that happens, you have something that logarithmically can exponentially increase, so that we go from 1 to 2 to 4 to 8 to 16 to 32 to 64, and you can see how the numbers can jump exponentially. At the same time, especially here in the United States, we have this weird synergy between the politics and public health. And we really see the emergence very glaringly of the politics of public health. We see fear and denial playing out. We see competing priorities, which are very real priorities: getting children to school, getting the economy going. These are all very real, but competing priorities to epidemic control. We have very disparate access to care. We have no single command and control center like many countries. If you think of waging a war, you have one command and control. But in our war against this virus, we have many people in charge. And that has, in days when it's not a crisis, there's beauty in that innovation and that dynamism and that flexibility. But when you need all hands on deck doing the same thing and doing it correctly and consistently, when we have no single command and control, that makes things very hard. We have reduction in public health funding historically. We have just-in-time procurement, and if we have some time, I can talk about that some more and why that was a big challenge in the United States for personal protective equipment. And knowledge and awareness, yet skepticism. Epidemiologists and virologists have predicted something like this pandemic that we are in for many years, and you've probably seen movies about it. Yet there has been skepticism and reductions in funding to take the measures we know would work. So there have been pragmatic challenges, and this is a slide from the Kaiser Health News that shows the incremental but steady decline in public health funding, and this is from back in 2008 until last year. And we have had federal prevention and public health funds consistently have gaps or shortfalls. Originally enacted funding was far higher than that which was actually received for public health. This is an example of the R0 principle that I showed, and I won't go into detail of this, but just wanted to have this information for you if you are interested to read a little bit more about this. But it's important to remember this: when the replication or reproductive number is greater than 1, the possibility of an epidemic is there inherently. And what we see now with COVID-19 is that it varies between 1.5 people. So for every person who's infected, they will infect between 1.5 people and 4 other people. And when you think about trying to break the chain of infection and get all of those 4 people isolated and quarantined, it's a very difficult task. And I'll just point out the top here, measles, and why we rely so heavily on the measles vaccine, because the measles has a very high reproductive number, between 11 and 18 people. So if I have the measles, I have the potential to infect up to 18 people. And we've seen problems with measles breakouts in the United States and in the New York area very recently. So another thing I wanted to show, and again, I won't go into great detail, but it's here for your information, and I'm happy to answer anyone's questions or comments at another time by phone or email. But this is simply to show that when you hear things like, well, you know, it doesn't kill a lot of people, most people will be fine with COVID. Yes, that is true, but because it has a R0 of greater than 1, we have the risk of many people being infected. So although proportionally very few people die, the absolute numbers of people that potentially can die is great. And so we've heard today in the news this morning, there was again discussion about herd immunity. And herd immunity is something we know from public health works. But to do that with COVID-19, to just continue with our lives as they were before, would require an inordinate amount of people to become very ill and many of them to die. So you can see here in red that even though the case fatality rate is low compared to SARS and MERS, it's only about 4%, which is still significant. The number of people who actually were infected by the time of this study were far greater than what we saw in SARS or MERS. And the numbers of dead was far greater as well. So proportionally, the number of people being infected and dying is high. Do case fatality rates improve over time? Yes, they do, but they do not go down to zero. And they do improve, as this slide shows, all of these lines going down, is because we're catching it earlier, we're getting an understanding of what therapies may help, and people may be getting what we call lower viral loads because they're taking measures to protect themselves, such as more hand washing, more social distancing, and mask wearing. But again, the fatality rates do not go down to zero. And we see that in the United States now as the numbers of people being infected and getting sick is beginning to overwhelm some of the hospital systems. So does risk decrease over time? And this is something Arden and I battle with a lot. And he'll say, well, the prevalence of the virus is far less. There's less than 1% of people testing positive in New York. And so yes, the risk for us has decreased if we're out and about in New York. The risk, the probability that we will come in contact with someone has decreased. That is true. But the risk is still there. And that's why when we talk about risk, it can be very tricky because we know that it is out in our communities, and I'm helping to lead up the contact tracing program here. So I know about people testing positive and how many are popping up like popcorn. So yes, the risk is not like it was back in June in New York City, but the risk is still there, and it's based on individual encounters and how those encounters take place and for how long, and then that is the potential risk for spread. What I wanted to show in this slide as well is that the risk is different for different people, and we'll talk about social determinants of health in a moment, but this is to show that amongst health workers, I'm a nurse, so I'm very passionate about this, is that the numbers of health workers overall dying from COVID or becoming ill with COVID has decreased over time as we learn more and we get better personal protective equipment. But throughout, the risk is greatest for those who are working most closely and for the longest period of time, this high touch care that shows the risk for nurses. And we'll talk a bit more about that. So the public health approaches going forward that we have are to prevent, detect, respond, and mitigate. And now we're in all of these. We're continuing to try to prevent new infections. We're trying to detect them as much as we can to isolate and quarantine, as well as to respond and mitigate. So our goal is to break the chain of infection. We know that one person can potentially infect one up to four, approximately 4 people, but we do know, as we've seen with the White House, that there are what are called super spreader events, where there is someone who is infected and infectious, so they're actually coughing or breathing out virus, who can then cause the spread to many more people. when there are people in a closed area, not social distancing, not wearing masks, who then can spread the infection to many more people. So our goal is to break that chain of infection. So COVID priorities across health sectors, we have public health priorities, we have health workforce priorities, and we have health system priorities. And they are to limit the spread of the disease and save lives, provide quality care for the critically ill, maintain essential and emergency services, and provide safe and effective care in a well-supported and safe environment. And I would like to add a ring to this circle to say that another priority is to maintain community cohesion and community, from Africa we say Ubuntu, this desire to work together. Because it's not only nice, it's essential for public health that we be on the same page, that we be together in what needs to happen to protect all of us. And that is often missing from the equation. So the public health strategies, as I said at the beginning, are the simple ones: hand washing and mask wearing. And I remember, and Arden can vouch for this, early in the epidemic, I was livid when I heard the people on the COVID task force saying not to wear masks. Because to me, as a nurse, as an epidemiologist, it made no sense. And I think this is one of the biggest missteps that we have made in this country, was to allow for that misinformation based on the fact that we simply did not have enough to protect our health workers. That's the truth behind this statement. And we allowed this politicization of a simple mask. So what are the strategies? Those basic hygiene, infection control. And you can see from this picture how a cough or a sneeze literally propels virus out into the air. So what are our strategies beyond infection control? We have surveillance systems, and we are lucky to be in New York, which actually has an amazing surveillance system. We can get down to the community, even down to the streets where the most infection is. And that is not the same in many parts of the United States. We have a health system, a health authority in New York, which is one of the best in the world. And so our surveillance system is very strong. We have containment to slow the spread. And that means isolating people who are ill and sick, following up those who have come in contact with them, and encouraging, promoting, helping to support people to stay in quarantine for 14 days. That is what is called contact tracing. And when we do contact tracing, we discern if someone is what we call a quote unquote close contact. And what we mean by a close contact is someone that was within 6 feet of a person for 10 minutes or more. And what we know, and again, we're still learning, what we know is that it's that amount of time and that proximity to another person that provides the environment that allows enough virus to be transmitted from one person to another to cause infection. Now this changes if, for example, we're both working out, or I'm singing or talking very loudly, then those parameters change. But in general day-to-day interactions, irregardless of wearing a mask, 10 minutes, 6 feet. And that's why we continue to say social distancing, social distancing. We also have mitigation to reduce the severity of the epidemic, to try to reduce the illness, the morbidity, the mortality, as well as disruptions to our economic, political, and social systems. And this is where faith leaders, I believe, have a central role to play in being a voice of what is needed to come together and be on point together to do what is needed to protect all of us. And that is the social fabric of our communities. And obviously social distancing, and then communication, increasing public health literacy. What do they really need to know? Those basic facts. And again, we've had missed opportunities in the US and challenges where people were not told in clear, consistent terms what is going on. And that is what people need, because people are very savvy. People will quickly pick up on the dissonance and on the something that doesn't make logical sense, and then begin to think, well, what's really going on here? What I'm hearing is not adding up. So just quickly, you may hear the two words isolation and quarantine. Some of you may have had to go into isolation, and some of you may have had to go into quarantine. So isolation is for those who are ill, and quarantine is those that are close contacts. And the purpose of the close contacts going into quarantine, again, is to ring fence around the potential virus. Although contacts may not become infected, we don't know, and they are most likely the ones to become infected because they have had a known exposure to someone who has recently tested positive or is showing symptoms. Again, it's 10 minutes and 6 feet. And so this is all about working together to break that chain of infection. If all of us did that for the next 2 weeks and did it religiously, no pun intended, we'd be over this virus. But it is very difficult to do. It comes down to human behavior, which is very hard to modify and control. And it's not unsurprising that in countries where there are stronger social controls, they have been able to dampen this down faster because it's reliant on us and our individual behavior. This is a nice graphic from Johns Hopkins that shows the small window of opportunity that we have to act. And that is what we are doing in our contact tracing program. We have this small window of a few days here, as you can see, from the time that a person becomes sick, so this is the case, and they come in contact with someone who doesn't have the infection, but they either cough or breathe or sneeze on them in an interaction that makes them exposed. And we have this short 2-day window of opportunity to find them and to put them in quarantine and have them be in quarantine to make sure that hopefully they do not develop symptoms. But if they do, that they are isolated, they are ring-fenced to break the chain of infection. So COVID-19 disease presentations, it's important to know that we are still learning as we go, but we do know that there are people that are asymptomatic, there are people that have mild, the majority of us, about 80%, have mild to moderate symptoms to mild pneumonia. Others, about 15%, have severe disease, dyspnea or shortness of breath, hypoxia or low dips in oxygen levels, and lung dysfunction. And then critical condition, about 5% of people. But again, 5% of a million is a lot of death, a lot of people. And that is what we are seeing in the United States right now. And this comes from respiratory failure, shock, organ failure, and we also see this very significant inflammatory disease. And this is just to show from the most recent data that we have about a case fatality rate of about, I think this was 2.74%. So we have about over 7 million cases, and yesterday about 15,000 deaths. So that's about not only 2.73% of people who get this dying, but you can see that's 215,861 lives that are lost. So don't be fooled if someone says that, well, the majority of people do fine. Oh, it's very few people. It's less than 5%. It's only 2% or 3%. That in public health terms represents 200,000 lives. So where are we today? As I said, we have about 7 million cases in the US, almost 8 million cases. The world has 38 million cases. But as you can see from this Johns Hopkins map, the red is where there's a lot of infection. And you can see that the United States is very heavily impacted compared to the majority of the world. And we currently have the most number of cases. Granted that other countries may not have the same amount of testing, but we don't see, and I work very, very closely with a number of countries in Africa, we do not see the numbers of people coming to the hospital and dying like we have seen here. So the US, about 7.5 million, South America, about 8 million, that's across all of South America, so many countries. In Africa, about 1.5 million, and great regional differences in the numbers of people being infected there. South Africa has been heavily hit hard. It is a hub, an airport hub, and other African countries that are more isolated only have a few thousand cases. And then Asia, we know, is a very large population and has had over 11 million cases. And Europe, about 5 million across all of Europe. So the global burden of disease, the top 5 countries with the most COVID cases, again, we are #1, something we don't want to be #1 at. Second is India, third is Brazil, 4 is Russia, and 5th is Colombia. So public health attitudes, behaviors, and beliefs related to COVID-19. This is the last part of my talk. And again, this is simply a picture of a mask and reminding us that this simple public health measure, which has been used for hundreds of years, has suddenly become something of a political statement. And we need to really unpack why that is, because we know simple hand washing, simple preventive measures like wearing a mask do make a difference. So mask use around the world is highly variable. And you can see from this map in April and June, the numbers of people using masks in South America and in Europe was far better than in the United States. And this is early in the epidemic when there was a lot of miscommunication, misunderstanding in the United States. But we can see comparatively our mask use, people who said they always wear a mask was far less than other countries. But as you can see, by June, it was improving, especially in hard-hit areas like the Eastern Seaboard, New York, Connecticut, New Jersey, and in California. Here is a more recent mask use map, but you can see again, there is great disparity between high use on the coasts and in some of the South, and far less use in other middle areas of the country. COVID attitudes, behaviors, and beliefs are changing though, and we see this is a survey from the US where an increasing percentage of people are aware that they need to keep 6 feet apart, agree that groups of 10 or more people should not be allowed, and this was back in June, and that 80% supported stay-at-home orders and non-essential business disclosures. So what this says to me is that the majority of people get it. They understand the measures that need to be taken, but there are enough people, this 20%, who don't or don't want to, and who are potentially helping to drive this chain of infection. So factors affecting behavior, this is another study from the Pew Research Centers that showed partisanship has the biggest role to play as a factor in affecting people's behavior towards COVID-19, which I found very, very striking. Much lower were race, geography, gender, and age. But partisanship came out clearly as the front runner in a factor driving COVID behaviors. So the community impacts and why you are so important as faith leaders is the social disruption and the impact on social cohesion. the divisiveness in the United States, which has increased over the years, has taken on new and really concerning, sometimes violent, more violent dimensions than we've seen in the past. And I believe faith leaders are central to reining this in and putting in front of us what is really going on here and how we are called as people of faith to say that is an affront to what we believe to be loving, compassionate care for ourselves and for others. But we have seen this disruption, which has been very real in people's lives. And again, remember, fear and denial are part of the human experience and drive a lot of the responses that we see in disruptions to education. Working parents, especially parents of young children, I do not know how they are doing it. It must be very, very difficult. Frontline workers, and that's not just nurses who are at the highest risk or EMTs or doctors, but grocery workers, toll collectors, bus drivers, all of these people that have to go out every day and don't have the luxury like I do of sitting in my own office, who are constantly confronted with that risk. Someone who comes up to them who won't wear their mask, or someone who is shouting at them, and they have to be out there every day confronting that. We have job loss and economic uncertainty, which has impacted all of us and all of our congregations, and racial disparities in morbidity and mortality. And I want to talk a little bit more, and I'm almost done and want to leave time for questions and discussion, is the social determinants of health. COVID-19 has put a spotlight on what in public health we have known, is that healthcare is political in the United States, highly political. Access to care is deeply divided in our country, and that there are profound social determinants of how healthy you are in the United States. And we see this with COVID-19. Racial and ethnic disparities are great. 33% of hospitalized COVID patients are Black African Americans, though they constitute only 13% of the population. That is the truth, that is the science, that is just as Black men are much more likely to be put in prison, Black people are much more likely to be hospitalized. It's not because their bodies are any different biologically or anything else that they are taking on behaviors that are more at risk. It is because of these deep underlying social determinants of health. Not having the healthcare, the nutrition, the access to services throughout one's lifespan that affect your overall resilience and ability to protect yourself. COVID-19's devastating impact on African Americans can be seen in every state. While, for example, in Louisiana, they are 32% of a state's population. They have been 70% of COVID-19 deaths. That is immoral to me. That is a glaring evidence of deep-seated disparity, racism, underlying inequality that is not only affecting one's quality of life, but ability to live. Illinois, while Black people account for, only 15% of the population, 42% of the deaths are amongst African Americans. And it goes on and on and on. And these are COVID-19 butting up against historical, socially driven, deeply rooted social determinants of health. And we have the intersection of race and ethnicity with COVID-19 risk factors and outcomes. Here we look at frontline health workers in New York City, and we can see that white people are very few in these circular pie charts of those that have to be out on the front lines. And the majority are Black, Asian, and Hispanic people who are doing the building cleaning, who are doing childcare, who are homeless, who are working on the front lines of healthcare, cleaning the rooms, providing the nursing care, providing the frontline services, working in public transport, working in drugstores and convenience stores. And this is just one of many examples of the disparity and the risks that are inherently there in our social structure. This is another example that shows that Black and Latino people in New York City are twice as likely to die from COVID-19. And this is across all of the measures, from being affected and not hospitalized to being hospitalized to dying. This is consistently there. We also see disparity by income percentile, which is a marker for many things: privilege, ability to isolate, ability to have health care and have a better overall health status. And you can see that it dramatically increases the lower we go with our income. We also see it in New York, again, showing how granular the data, how dynamic the data is that New York is able to show the case rate by zip code here in the United States in this right purple graph. And you can see that it's not where we are in Midtown or Lower Manhattan, but it's up in the Bronx and in Queens and in Staten Island, where there is far greater burden of disease. We also see geographic disparities in this slide, showing differences in hospitalization and deaths. On the left, we see differences in hospitalization, and here we see differences in the numbers who are dying. And this is a multiplicity of factors, including possibly the quality of the health services that are available, the ability to get into care, the ability to get into intensive care support. One more, just to bring the message home about testing. Testing is racially divided as well. And the one on the left shows from Dallas that testing sites are concentrated in wealthier, whiter neighborhoods. And in Chicago, retail testing sites leave behind Black communities. So testing sites being more commonly located in areas where wealthier, whiter neighborhoods exist. And then lastly, amongst elder adults, we know that they have paid a heavy price and are at greatest risk. 8 out of the 10 deaths reported in the US have been in adults 65 years and older. And in New York, elderly have the highest rates of infection, hospitalizations, and deaths in the United States. And we can see in the bar chart to the right, this very stepwise incremental increase in the number of people hospitalized as age increases. And then lastly, talking about that deep-seated underlying social determinants of health, we talk about pre-existing conditions. And these are the pre-existing conditions that help to drive more severe cases of COVID-19, whether it's chronic liver disease, smoking, chronic renal disease, being immune compromised, heart disease, lung disease, diabetes, and other chronic diseases. So having chronic diseases and more importantly, having under or untreated chronic diseases or poorly managed chronic diseases puts one at an elevated risk of having a bad outcome with COVID-19. So decades of research have shown that these racial and ethnic disparities are great, even amongst students and residents who measure pain as lower in Black people, and this implicit bias towards people of color, even in health systems. In emergency departments, we know that non-Hispanic Blacks are 1/2 to 2/3 less likely to receive opioids for their pain. Studies have constantly shown that African Americans are less likely to get access to advanced treatments. And in the case of COVID-19, Black patients that exhibited COVID-19 symptoms were 6 times less likely to receive testing or treatment. When I read that one, I was just speechless. And this comes right to today, showing those profound, deeply rooted disparities. So a bit of a summary, and I'll end here on the social determinants of health. COVID pandemic continues to impact us. Certain populations have been disproportionately impacted. It has exacerbated existing health disparities. Disparities in outcomes are consistent with long-standing and well-documented socioeconomic factors and deeply ingrained racism. And these disparities in impact exist all over the world, but right now we're talking about here at home and how this is affecting our communities, our community cohesion, our ability to work together to get out of this pandemic. And this is something that I wanted to bring to you. This is something that faith leaders play a critical role in addressing, and why I felt it was important to share what I know and to discern what is the role of a faith leader. And the role of faith leaders is to be able to listen to and hear myths and the fears of people that are driving behavior, their fears of the unknown, dealing with that ambiguity, and somehow being a steady presence of logic and clear thinking is an important role that faith leaders have to play. Even when you are fearful and have concerns and questions, to be able to be that steady presence amidst the storm is very important right now. And so I wanted to be able to share what I know, to be able to empower people to be that steady presence, even when things are not as certain as we hoped. There are fundamental things we know we can do, and those are our bedrock. Those are what we put our faith in right now. And we can talk about specific religious service considerations, safe distancing, identified seating, social soloists versus in-person choirs, signage, trained ushers, etc. We can talk about that if you'd like, some of the special considerations you might want to think about. But I also wanted to bring to your attention, there is an app created by the Massachusetts Institute of Technology that provides a scientific way to identify how many people can safely be housed in a room, depending on a variety of factors, including what the people are doing, the size of the room, the height of the ceiling, the air quality, etc., to allow you some comfort in understanding what your congregation, your building may be able to hold and hold safely. So I'll stop here and I'll pull up this app. I'll stop sharing my screen, Bishop, if that is okay. Thank you. And we can go to some Q&A, and if you would like, we can show you that app as well.
Dr. Michaels-Strasser, thank you so much. That was not just a huge amount of information that's very helpful, but the perspective with which you shared it and your priorities on care and concern are really, really meaningful and helpful to us. So thank you for that, from sharing from your faith as well as from your knowledge. So let's turn it over to some questions, and Pastor Strasser, you get to moderate this part of the time together.
Thank you. Susan, the first question is for you. What's the status of the development of a reliable vaccine?
Great question, and we'll go into more detail on this tomorrow. In summary, I can say we're getting closer, but we're not there yet. There are many vaccines in clinical trials right now, and I will present those tomorrow evening to you. And as you have probably heard in the news, there is a sequence of phases that we go through in vaccine development, from first just seeing if it even conceptually can work, to trying it with small numbers of people, looking at the antibody reaction, and then seeing what is the right dose, and then incrementally trying it in phase 3 trials on more and more people. And that is where we are right now. We're in these phase 3A, 3B trials that looking at not only is it effective, or you may hear the word efficacious, is it effective? So most of them that have gotten to this point, we know have some evidence of being effective. That we have. Where we are now is looking at how effective they are and how safe they are in large groups of people. Just like we know that the majority of people will be fine, 80% will get through COVID-19, there is this small percentage of people, although the percentage is small, when you think of it from a public health population perspective, it's a lot of people. So we have to be very, very careful that these are safe to give to everyone, to millions and millions of people. So what we've seen with 2 clinical trials right now, J&J, Johnson & Johnson's clinical trial, and AstraZeneca, they have been stopped because of concerns regarding side effects, severe, and this doesn't mean headache or rash or pain in the arm. It's not those types of side effects. The AstraZeneca study was stopped because someone had what is called transverse myelitis, a very severe illness, and they're still looking into whether that was caused by the vaccine or not. I don't know what the illness was that stopped the Johnson & Johnson trial, but I can tell you that they aren't because of mild symptoms. Every clinical trial has a drug use safety board that monitors this, and there are barometers of reporting that are constantly being reviewed to see what the risk is. So we're getting closer, but we're not there yet. And tomorrow I'll show you a timeline of vaccine development. And we have taken what usually takes years and compressed it into months. So we have done, not myself, but people upstairs, literally upstairs, are working on the vaccine, are doing amazing things very, very quickly. But we are not there yet. And what has to happen to get there is still significant. These clinical trials have to get through enough people without these serious side effects and show that they actually are protective, and we're not there yet. We are part of a clinical trial here, and we are still on hold to actually begin phase 3 because of the AstraZeneca case in Europe that had transverse myelitis. So there's at least 20 vaccine trials going on, and they're all at different stages. And even then, when we get a vaccine, and I'll present this tomorrow night, it is going to take months we have a plan, or the US government has a plan of who gets it first. And obviously it will be those people who are most likely to become seriously ill, and frontline health workers and other frontline workers who are at greatest risk. So there is a planned rollout of the vaccine. That being said, I'm sure wealthy people will have access to it, as we've seen with the social determinants of health, but we are not there yet. We probably will not be there yet until the end of first quarter or middle of next year. But again, this is not, this is, I wouldn't say it's reading the tea leaves, but there is a lot of unknowns in this equation. I'll stop there.
Okay, the next question is this, Susan, for Susan. Most churches in New York City do not have HVAC systems, that's central heating and air conditioning systems, but they instead have boilers and hot water steam heat systems. The question is, how can we purify the air indoors to make in-person activities safer? I don't know if you have any thoughts on that.
Sure. So I'll talk about it first, and then if I could share my screen once more, I'll show you this app. Again, let's go back to the basics. Whether you're indoors or outdoors, the most important thing is wear a mask, stay 6 feet away of anyone else, wash your hands. Those are the most important, whether you're indoors or you're outdoors. Those are the best protections that we have. Coming together indoors, First of all, looking at seating. How can you seat people so that they're at least 6 feet apart from each other? How can you ensure that they all wear a mask and that they wear their masks properly? Not like this or like this, but they wear the mask over, fully covering their nose and their mouth. Those, again, go back to the basics. Those are the most important. If you can't buy air purification, and I don't know how much they cost, but I'm sure they're very expensive, open the windows, open the doors. These are all measures that can help to increase ventilation. And now I'll show you the app. Let me share my screen if you don't mind. Here's the app. You should be able to see this now. And you see here, it's the MIT COVID-19 Indoor Safety Guideline. And this is an app that you can use to decide. So for example, you go to these two variables, room specifications and human behavior. So let's say your room is, they do put church. Okay, so here's a church. Let's say our square footage is 900 feet. We have 1,900 square feet. Let's say churches are usually bigger. So let's say 4,000 square feet. We have a church that's 4,000 square feet. The ceiling, your ceilings are usually quite high. So let's just say 30 feet. Your ventilation system, you don't have any mechanical ventilation, but you have open windows with fans. Okay, so you have open windows and fans. You have residential window AC. You don't have anything different. You don't have any recirculation rate. So it's just your basic room without any special air circulation. So based on this model, it should be safe for this room to have 50 people for 20 hours, 100 people for 10 hours, 750 people for 1 hour. In comparison, current 6 feet distancing guidelines recommend no more than 111 people in this room. So out of an abundance of caution, it is saying that you could safely have 50 people for a prolonged period of time. And again, this is with a high ceiling, a big room, open windows with fans, and everybody doing what they need to do. And the second part of the equation is the human behavior. What is the exertion level? Are people exercising? I hope not. They may be standing and sitting. Are they singing? Are they speaking? And you can put in here singing. And are they singing at a whispered pace, or are they singing are they really singing out loud? And that you can see that it changes dramatically. If I say that people are whisper singing, they can be there for 14 hours, the 50 people. If we say that they are singing loudly, they can only be there for 2 hours. So see that dramatic difference there. And if they are wearing, let's say they're wearing just a basic quilter's cotton mask, they can only be there for 18 minutes. So things change dramatically based on human behavior. As I said earlier, you can put in, how well people use their masks. Maybe you know that some people just don't get it and they're not good at wearing their masks. You can change this around. You can change your risk tolerance. Do you want to, have a in-between risk tolerance, or do you want to err on the side of being super cautious? You can play around with this and see what it is. But again, this is a mathematical model. This is based on what the science we know. But step back from this, which is a cool tool developed by MIT, and go back to the basics. 6 feet, wear a mask, less than 10 minutes within that 6 feet. So what we've done at our church is, if we're talking with each other, we're outside and we separate 6 feet. If you're having church, we have like 2 or 3 people per pew, and they're all at least, if not more, 6 feet apart. I think it's even less than that right now. I think our church is just having people sit in every other pew so that there is even more distance front to back. We're not using, handing out a lot of materials. The singing, we don't have a choir, we have a soloist. So there's a lot of these variables that you can do. But again, it comes back to the basics. Keep that mask on, don't take off that mask, don't get within 6 feet, which can be hard because people love to come up to you and talk. But again, it's for 10 minutes. So if someone comes up to you for a moment, that's fine. But if it's 10 minutes, then it's a different story. I'll stop there. Go ahead, Art.
Got it. Next question is for Bishop. How do we meet a quorum for a congregational meeting if the maximum for gatherings is only 25 people in our building?
So we have found out from our legal counsel that congregational meetings can be held virtually, and that information can be found on our website under COVID-19 resources, the details about how to do that. So it's not necessary for people to be physically present to do the business of your congregation.
Thank you.
You're welcome.
Susan, how often does a church need to disinfect a facility after usage? You're muted.
I would say more often than you think. I'm pretty hyper about cleaning, but that's probably my training. But after every church service, I think the major touch surfaces should be wiped down. So the bathrooms, the bathroom toilet handles, the sink and the faucet handles, the pews, wiping down, especially where people are touching to get to sit down and stand up. I think those are the kinds of basic, cleaning practices. You don't have to go crazy, but just those surface areas, to clean them with Lysol or some type of spray disinfectant is a good idea.
Next question. What should we do, Susan, if someone in our congregation gets sick?
Well, first of all, care for them and pray for them. Make sure that they are connected to services to provide support. There are a lot of services through New York City. There are ways to get food to be brought to them. New York City should be calling them and asking them about their symptoms on a daily basis. One of the tricky things about this virus is people can be doing fine and then suddenly become quite ill. And so checking on people daily is a very good idea, especially if they live alone. If someone does become sick, again, they will be most likely tested, and that will put them into the New York City network for contact tracing. And what will happen is they will ask about close contacts. So it will start from 2 days before this person became sick or was tested. So for the 2 days prior to that, up until now, who have they come in contact with? Again, for 6 feet, less than 6 feet for 10 minutes. And that really is your measure. So I may today meet 20 people, but I will not be with someone close 6 feet for more than 10 minutes. And so even though I'm out, I'm working, I'm in the community, I will make sure that I'm never closer than 6 feet for more than 10 minutes. So even though I'm out and about moving, I won't have what are deemed close contacts. So if you in your church find out about someone who tested positive and they were in church on Sunday, and let's say it's Tuesday, they were infectious. They were most likely infectious at that time. But if you were vigilant to make sure that no one was standing together for more than 10 minutes, then no one should have been deemed a close contact.
Thank you. Bishop, any guidance or ideas about managing Christmas 2020? Remote, any suggestions or thoughts?
So we are working on that now here in the office, trying to provide appropriate guidelines, but the reality is that the guidelines that are already in place apply even if it's Christmas. So whereas we'd like to have the 200 people or so in church, the guidelines are still restrictive. And probably, as you alluded to, Pastor Strasser, most of it's going to have to be remote. In fact, given what Dr. Michaels-Strasser has said, I think this is just my reflection that much of our worship is going to continue to be remote or very limited in person until it sounds like next summer. Once there's a vaccine that's widely available. So just to prepare ourselves for that. And again, if you're thinking, okay, what we could do for Christmas Eve is have 4 services instead of 2, don't forget that that means cleaning the church thoroughly in between each of those services. And my dear colleagues, what is that going to look like for you? Doing 4 services with that much space in between, that sounds very stressful. So the more that you could do online is probably a better stewardship of your energy as well. But having said that, we will come out with clearer guidelines as we get closer. Every day we monitor what comes out of the governor's office and follow his recommendations as well. And as some of you saw last week, as appropriate, we will bring that information directly to you. So when some of our communities in Brooklyn, Queens, Rockland, and Orange counties were in the red zone, staff called all of those congregations to let them know that affects their worship attendance. So we're trying to bring that information to you as it comes out.
And that gets back to the nuance of public health, these red zones. You know, we're lucky to have that information in New York. Many places don't. And so you can calibrate the levels of risk because we know that there is a lot of circulating virus in those communities right now.
Could be the last question for Susan. How can we prepare for our congregation area? Just so you know, Susan, a lot of our pastors are all over downstate New York. We prepare for an outbreak in our congregations area.
Well, first of all, let's do as much as we can to prevent. So continue to be consistent and clear, calm and clear in the messages to people to prevent as much as possible. But I think what people need to do, just like we do if there is a potential hurricane or a fire, we prepare, and we prepare to have systems in place to support each other. We have the wider health system that is there to support people, but keeping that connection to people, even if it is virtual, preparing for that, preparing for what we could anticipate if there is another surge, which is happening in many parts of the United States. Thankfully, in New York, we learned a hard lesson early on, and people have really come on board and doing the right things to prevent another outbreak. But the best thing that we can do is go back to that simple picture of breaking the chain of infection, is putting a ring fence around the infection and helping those people. I don't like to call it like punitive. I call it holding them in care, you know, holding them in isolated care so that they can be protected and cared for and reduce the risk of transmitting to someone else. And it's those moments when someone has to go out to get groceries or they need to go to the doctor's office. These are the moments when things can spread. And so those points are the ones that we need to think about. How do we help people who are infected stay home, and how do we help those that are deemed close contacts to stay in quarantine? And helping them to do that is the best way to slow down the spread of the epidemic, while those that are healthy remain doing what we know works: social distancing, less than 10 minutes, wearing a mask, washing your hands.
Roberto, is that time? I have one other question that came to me privately.
It is time, and we have more questions as well. So we're going to try to publish some answers in our pages, Pastor.
Okay.
Again, Dr. Michaels-Strasser, thank you so much for sharing this time with us. Yes, much appreciated.
My pleasure.
And if you need more information, as Dr. Michaels-Strasser referenced, there's a second webinar tomorrow night, starts at 7 o'clock. Roberto, people need to register for that as well, correct? You can't just show up tomorrow at 7.
That's correct. And the registration is still open. So just go back to your email from last week and you can access that link. I can share it here.
Okay. Pastor Strasser, thank you for your help with this webinar. Much appreciated. I'm going to close you all with prayer. Let's stay in touch. We're here to help you any way that we can. So don't hesitate to reach out. Again, keep your eye on the website where we'll be answering some more of your questions and have currently updated information. But if it looks too overwhelming, you can always give us a call, shoot us an email. We'll be happy to reach out to you and help in any way that we can. Okay. I invite you to join me in a word of prayer as we conclude this time together. Let us pray. Gracious God, way back when you brought your people into the promised land, you set before them a choice, life or death. We realize that that choice faces us every day in our personal lives and in our lives together as community, as citizens of this nation and of the world. We also know that your Spirit guides us into making the choices for life. That clearly your Son's witness to us is that we are to be about life and love and mutual care. We thank you for the wisdom of those who are able to guide us in making those choices thoughtfully with information. We especially thank you today for Dr. Susan Michaels-Strasser and for her passion and for her service, not just to us, but of course to so many of your people who are impacted by her work. And we thank you that you give us that opportunity as well as your leaders in these days. Help us to choose life for ourselves, to steward our energies and our patience so that we are able to then shepherd those who you have placed under our care. Keep us mindful of you. Give us time to be in contact with you, to find strength in periods of peace and quiet and meditation, to find those moments that are afforded to us, to be with those we love safely, to get energy from our relationships. And help us too, Lord God, to look to the future, to look to a time when life will be more manageable, but keep us vigilant to those most in need in our communities, that those things that we have learned in this time would not be lost, but that we might continue to be your champions for the good of all, but mostly that we would be defenders of those who are most marginalized and affected by the inequalities in our society. Make us champions of our siblings of color, of those most in need. Help us to speak for them when no one else will. And give us the determination of our faith to be both prophets and priests in these days. For we pray these things in your holy name. Amen. Now, my friends, may the Lord bless you and keep you. The Lord's face shine upon you and be gracious to you. The Lord look upon you with favor and give you peace in the name of the Father and of the Son and of the Holy Spirit. Amen. Thank you all very much for your time and for your ministry. Have a blessed day.